Step 1. Prior to insertion, the integrity of the tracheostomy tube cuff and inflation system should be checked by fully inflating the tube cuff. If satisfactory, fully deflate the cuff, smoothing it back towards the flange as it deflates. This will reduce insertion force and avoid cuff rupture during tube insertion. Check to make sure the inner cannula can be inserted and removed from the tracheostomy tube. Step 2. Ensure that the tracheostomy tube introducer moves freely in and out of the tube by applying a small amount of lubricating gel to the introducer. Ensure that the introducer clicks securely onto the tube and that it can be easily removed. The guiding catheter should be checked to ensure free movement in and out of the tapered dilator. A small amount of lubricating gel may be applied to both the pre-dilator and the outside of the tracheostomy tube to help reduce insertion force. Attach the 10 milliliter syringe to the needle and cannula assembly. Use of saline in the syringe may be used to confirm entry of the needle cannula assembly into the trachea. Step 3. Identify and mark the anatomical landmarks, including the thyroid cartilage, cricoid cartilage, tracheal rings, and the sternal notch. The suggested sites for tracheostomy tube insertion are between the first and second, or second and third tracheal rings. It is essential that before any procedure is performed, relevant anatomical landmarks are clearly identified. Step 4. If not already in place, a patent airway must be established with a cuffed endotracheal tube to ensure adequate oxygenation and ventilation during the procedure. This also allows for rapid re-intubation in cases of difficulty. After appropriate disinfection of the surgical site and local infiltration of epilidocaine anesthetic, make a 1.5 to 2 centimeter incision at the chosen insertion site. Perform exploratory blunt dissection to palpate the anatomical landmarks and determine the possible presence of anterior jugular veins. Palpate the tracheal rings and select the site for needle, guide wire, guiding catheter, dilator, and tracheotomy tube insertion. Step 1. Suction the pharynx and deflate the endotracheal tube cuff. While viewing through the bronchoscope, reposition the endotracheal tube so that the cuff is just below the vocal cords. Reinflate the cuff. Proper repositioning of the endotracheal tube away from the needle insertion site helps prevent puncturing the cuff or impaling the endotracheal tube with the needle cannula assembly. Hold the endotracheal tube in position, ensuring the head and neck are positioned midline. Step 2. Insert the 14-gauge needle and cannula with attached saline-filled syringe caudally into the insertion site. This reduces the likelihood of the guide wire being passed into the pharynx. Advance the needle and cannula, if necessary stepping off the tracheal ring, until a sudden loss of resistance is felt, followed by free bubbling of air into the syringe while aspirating. This confirms entry of the needle into the trachea. Gentle in and out movement of the endotracheal tube will help determine if the endotracheal tube is impaled by the needle. If such is the case, the needle will move up and down as the tube is moved in and out. In such cases, the needle and cannula should be removed and reinserted after the endotracheal tube has been withdrawn at least 2 centimeters. Once the needle and cannula have entered the trachea, they must be held immobile so that the tip does not drift out of the trachea, which will result in incorrect placement of the guide wire. Care must be exercised to ensure the needle, guide wire, guiding catheter, and dilator do not perforate the posterior tracheal wall, resulting in potentially life-threatening injury. Once the needle has been partially or completely withdrawn from the cannula, never reinsert it, as this could result in the cannula being cut and left in the trachea. Leaving the cannula in place, withdraw the needle and syringe. Connect the syringe to the cannula and withdraw air to reconfirm that the cannula is in the trachea. Remove the syringe. Step 3. Next, take the flexible guide wire and guide wire introducer and straighten the J-tip using the guide wire introducer. Insert the guide wire introducer into the plastic cannula and advance the guide wire until the first mark can be seen in the cannula and at the level of the skin. Great care should be taken throughout the procedure to avoid kinking the guide wire. Confirm free movement of the guide wire by moving the guide wire, without resistance, in and out of the cannula prior to removal. As the guide wire will be used to guide components into the trachea, it is important to frequently check the free movement of the guide wire in and out of the components and trachea. Remove the guide wire introducer followed by the cannula. This leaves the flexible guide wire positioned in the trachea. Step 4. Advance the lubricated 14-gauge pre-dilator over the guide wire through the soft tissues until resistance is felt on the tracheal wall. With a gentle twisting motion of the dilator, advance the dilator to penetrate the pretracheal tissue and anterior tracheal wall. Remove the dilator, leaving the guide wire in place, ensuring that the first mark on the guide wire is at the skin level. Step 5. Pass the long guiding catheter over the guide wire into the trachea in the direction of the arrow mark until the black safety stop on the guiding catheter is located at skin level. Align the proximal end of the guiding catheter with the proximal band mark on the guide wire to ensure correct insertion depth of the wire guiding catheter assembly. The next stage is tracheal dilation. Prior to insertion, immerse the distal end of the tapered dilator in sterile water or saline to activate the lubricious coating on the dilator. Step 6. Pass the dilator over the guiding catheter until it reaches the black stop. The proximal mark of the guiding catheter is just visible at the handle end of the tapered dilator. While stabilizing the guide wire and catheter assembly, insert and partially remove the tapered dilator several times in order to overdilate the trachea to a size appropriate for the tracheostomy tube. The dilator is marked with a 38 French gauge and a maximum insertion depth mark. The dilator should not be inserted beyond the maximum depth mark. Care should be taken not to pull the guide wire guiding catheter assembly out of the trachea when removing the tapered dilator. Reposition the guide wire guiding catheter assembly and remove the tapered dilator, leaving the guide wire guiding catheter assembly in the trachea. Air will exit through the tracheostomy stoma, confirming the correct placement of the dilator. Tracheal dilation is now complete. Step 7. Pass the lubricated tracheostomy tube loaded onto its lubricated introducer over the guide wire guiding catheter assembly into the trachea with a slight twisting motion. Hold the tracheostomy tube flange and connector firmly while removing the introducer and guide wire guiding catheter assembly as a unit in an arc motion toward the patient's feet. Step 8. To ensure a clear airway, suction any blood or mucus that may have accumulated in the airway during the procedure. As required, insert the inner cannula until a snap is felt, ensuring proper positioning. Inflate the tracheostomy tube cuff with an appropriate volume to obtain a tracheal seal. Move the breathing circuit from the endotracheal tube to the tracheostomy tube. Tracheostomy tube cuff pressure may also be measured to ensure proper seal of the cuff against the tracheal wall. Correct placement of the tube should be confirmed by techniques including auscultation, capnography, oximetry, bronchoscopic visualization, and/or chest X-ray. Confirming the tracheostomy tube placement following the procedure via bronchoscopy will prevent paratracheal placement that can lead to hypoxia, subcutaneous emphysema, or pneumothorax. The tracheostomy tube should be secured using the supplied Portex tracheostomy tube holder. A tracheostomy dressing may be applied at the stoma to absorb excess secretions and facilitate proper stoma care. The endotracheal tube cuff should be deflated and the tube withdrawn from the pharynx.